Welcome everyone. We are here today providing you this recording on the new residential aged care facility medical services that are available. I'm with my colleague Riwka Hagen and myself, Kim Poyner, on behalf of the Victorian Tasmanian Alliance Primary Health Networks. We're going to provide you an overview today on the new temporary item numbers for GP, mental health and allied health services.
Hi Kim, good to catch up with you. Perhaps a quick introduction from the two of us. I'm Riwka Hagen from Medical Business Services and Kim Poyner from MediCoach. We're really pleased to be with you to present this series. I would like to start this session with an acknowledgement of country. Certainly in the spirit of reconciliation, we acknowledge the traditional custodians of the lands on which we meet today and pay our respects to their elders past, present and emerging, and a hearty welcome from Dja Dja Wurrung country where I am located today. So as we kick off this information webinar, we'd like to just draw your attention to quite a robust resource that we have developed to go along with this webinar series to help you get your head around the complexity of the new item numbers and the current service items available for residential aged care facilities. It's available as a PDF, and we will very likely make this available in a couple of different formats because it's a really beefy document. So watch out for further links as part of these recordings so that you can download this resource and review that at your own leisure and use that hand in hand as you're developing your RACF services. So I'm going to hand over to Kim to have a little bit of a talk about what this is all about, why are we here and what we're talking about. Kim, take it away.
So what is available? We know that residents must have a shared care plan in place. So item number 731, and we're going to walk you through the new item numbers. And so what's available? We know that residents must have a shared care plan in place. And we know there's additional 5 services, and the 5 services are aligned in allied health for physical therapy. So that's exercise physiology, physiotherapy and OT. And they can only be accessed after the initial care has been received for the 5 EPCs associated with their shared care plan. And we're going to talk a little bit deeper dive on those points in a moment. There's also call out fees for GPs and OMPs and allied health. There's longer initial assessment consult fees for allied for chronic disease management services. There's longer Indigenous health follow-up services, mental health services, psychiatric.
That's a brand new one, isn't it? That was like completely not there prior to this new development as far as the MBS is concerned.
And psychiatric assessment management plans and telehealth services. Why are we doing this, Riff? It's a response to the Royal Commission. And I want to provide context to this because I think a lot of people probably may not have had an opportunity to go and read what the Royal Commission found. And it's really quite, significant in terms of its findings. And there's 6 recommendations that come as a consequence to this. So they found that the aged care workforce is under-resourced and overworked, but it's now also traumatised as a consequence of COVID-19. And as we all know, care workers develop really close relationship with residents, and many are grieving for residents who have died after contracting COVID-19. Others are anxious about bringing the virus into their workplace or home to their loved ones, and we pay tribute to the aged care workers and the vital work that they do. Never before has the aged care sector in Australia faced a challenge like COVID-19. There's some reporting in there, some facts and figures there, Riff. As of 19th of September, 844 people have died in Australia as a result of the virus. And of these, 629 were in aged care homes at the times of their death, although many died in hospital. The tragic impacts this virus has been felt across the nation, and events such as this pandemic and the consequential social, economic and day-to-day life impacts are beyond anything in the living memory of most in this country, with the exception of those people who were born before or during the Second World War. So this is incredibly profound, isn't it? And the time that the inquiry was announced on the 17th of May in response to the COVID-19 in aged care outbreaks, we had outbreaks in 3 homes in suburbs of Sydney and New South Wales. So we also then had major outbreaks in Victoria, and unfortunately we're still seeing this in 2021. So there were 6 recommendations, as I stated. Firstly, the Australian government should fund providers to ensure there's adequate staff. We talked about workforce shortages before, to deal with the external visitors. So the industry code for visiting residential aged care homes during COVID-19, the visitation code, can be modified to enable a greater number of more meaningful visits between people receiving care and their loved ones. Second, the Australian government should create Medicare benefits schedule items to increase the provision of allied health and mental health services to people living in residential aged care during the pandemic to prevent deterioration in their physical and mental health. Any barriers, whether real or perceived, to allied and mental health professionals being able to enter residential aged care facilities should be removed unless justified on genuine public health grounds. And why is that important? I just want to really respond to there's been reduced mobility and deconditioning, i.e. muscle strengths and fall risk, inactivity and isolation due to the lack of social contact.
Been quite dire, hasn't it?
Oh, absolutely. It's heartbreaking. And number 3, the Australian government should publish a national aged care plan for COVID-19 and establish a national aged care advisory body. And finally, the Australian government should arrange for the deployment of accredited infection prevention and control experts into residential aged care homes. So we're looking at the funding models now, aren't we, Riff? We're looking at what is it that people are going to be able to do as a consequence of having this Royal Commission. So we'll just flick on to the next slide. What are we trying to achieve here? We're trying to get better health outcomes for our patients and our residents in residential aged care facilities. That's paramount, their quality of life. We want to also increase their sense of well-being, mental stimulation, engagement in activities such as art, music and sensory therapy. We want to improve their physical function, focusing on prevention and early intervention, maintain and improve their mobility through strength, balance, endurance, reducing frailty and their falls risk and encouraging independence, improving and maintaining their cognition, so having behavioural strategies, and dementia management. We're going to have a look at that in a little bit of a deeper dive in a moment in the next slide. Reducing hospitalisation, preventing healthy ageing, obviously reducing the impact of CDM and disabilities. So chronic disease management, how can we be more proactive in this space? Coordination of activities with residential aged care facility staff. So mobility, hearing, sight, speech, swallowing, nutrition, foot health, training aged care providers, looking at skin integrity and reducing, breakdown, investing in equipment to assist, looking at how can we slow the progression of conditions and provide safe and enjoyable activities.
It's quite a list there, isn't it? Lofty ambitions. And you can just kind of really sense through that listing of what are we trying to achieve, of how meaningful this work and these services would be to our aging elders in the residential aged care facilities. And I think from the primary care perspective, we are sometimes a little bit removed from those direct outcomes. And it's just so worthwhile, isn't it, to just kind of reflect on the why are we doing this, and why do we choose to engage with sort of complex service provision because of these outcomes.
For sure, Riff, and I think we need to know that health professionals are going to be motivated, right, if there is an intrinsic reason on why we're providing these services. So I really want to highlight not only what, but essentially why. And now we're going to look at how, Riff. Tell us about the how.
Let's look at the how.
Let's look at dementia.
Talk about dementia.
So again, there's some additional services that are going to be available. And one of the recommendations is advising on the use of modalities other than speech, particularly what they're going to underpin in terms of behavioural changes, and obviously offer strategies to assist and manage. So they're looking at music, art and sensory therapy to reduce agitation, which is absolutely brilliant. We've seen great evidence supporting that. Retained abilities and strengths to develop alternate strategies when skills are gone, and adapt the environment to facilitate optimal functioning and minimise distress.
And this is also how you can see that overlap between sort of the traditional allied health services and the mental health services as well. And, you know, there's not really sort of a start-stop to either of them. They just work so closely together, don't they?
Beautiful.
Okay. All right, so I guess to get some context around what are the new services available, it's really worthwhile to just kind of reflect on where are we at now? What is the baseline of the services that have already been available up to this date? And this is useful, especially for, I guess, for practices who are looking to engage more with their residential aged care facilities, to just kind of paint that picture of what's been available to this date, and then how are the new services different to that. So the existing item numbers, let's start with the flag fall or the call out. That's been around for a little while now, in that you know, GPs and OMPs are able to tap into a flag fall, so that the first service and subsequent services to residential aged care facilities does attract the one item number for the visits, so the totality of visits on any given occasion to a residential aged care facility. And that's kind of to help with the travel costs and sort of that flag fall fee. I guess you can sort of liken it to a taxi flag fall fee, can't you? We've also had available now for a long time just your stock standard residential aged care facility attendance items. So that's short, standard, long and prolonged consultations. There's really not anything that's terribly new to that. Then there's been the item number 731 for GPs, the contribution to a multidisciplinary care plan or a review of an RACF developed multidisciplinary care plan.
And I think the key word there is contribution, isn't it, Riff? And
yes, it is.
When we get to look at the comparatives of what's new coming up, I think it's really important to emphasise just that key word there.
Yes, so, oops, that's sort of flipped through. In terms of the contribution, that really relates to the fact that the actual care plan is developed by the RACF, and that is done because they are mandated. That has to be done for every new resident that comes into an RACF. And so that care plan has been developed, and then the GP really provides that contribution to it. And that's kind of why that language is used in this particular item number. The Medicare rebate is given here effective from the 1st of July 2021. And that item number is still there, will still be there. So again, we'll tell you a little bit about new sort of comprehensive care plans and how they are a little bit different. So in addition to that, that care plan, also a very common service is the comprehensive medical assessment. So that can be likened to other medical assessments that are traditionally undertaken by GP practices, and the equivalent numbers there are sort of the item numbers 701 to 707. So those item numbers are also available for this assessment for RACF residents. So depending on whether it's a short, a standard, a long or a prolonged, didn't quite get that out right, prolonged health assessment, that would determine whether you use item 701 or all the way up to the scale of the 707. So that's already been there. That's not going anywhere. That remains unchanged.
So time-based, right? And you're going to talk about my favourite one coming up.
Oh, how about you talk about this one, Kim? Because I know you're itching for it. Tell us about case conferencing, Kim.
Case conference is where you get that 3D input of communication, and we know that the communication, when we have it internally really strong and externally to other providers that are wrapping around as an interdisciplinary team around a patient or a resident in this instance, we know that we're going to get better health outcomes. We know communication in a 3D form means that people are less likely to have to trawl through information, and they can ask questions in that point of care time. So case conferencing against time-based item numbers. Do people need to be face-to-face? No, they don't. And we know that we can provide a lot of comprehensive knowledge rather than that fragmented, isolated information that can often get missed if it's just embedded into case notes.
Excellent. Then we move on to the RMMRs, the Residential Medication Management Reviews, item number 903. Now, I do want you all to just be aware that through the mind map and the additional resources, you also have access to all the item numbers for the OMP, so the non-VR GPs as well. So we're certainly not leaving them out. So the medication management reviews are all about, safe use of medication and reviewing that. That's done in consultation with pharmacy, and they are hugely important in order to ensure that medication is taken safely, and that there is really close scrutiny of how that's impacting on the residents as well. So again, that is unchanged in this space. There's also after hours services. I won't sort of spend too much time on that. These are also attendance items, very similar to the ones that were mentioned just before. And lastly, there is also, as part of the practice incentives program, service incentive program, there are tiered payments available to accredited practices who are registered for the practice incentives program. At this point in time, the additional payments available to practitioners who visit RACFs is based on the number of attendances. So for any GP who provides more than 60 attendances per year, there is a payment available of $1,500. And if a GP provides more than 140 services per year, there is a payment of $3,500. So it's actually a stepped approach in that clearly the maximum amount that a GP can generate from those services is the addition of those two, so that's $5,000. Now, I've put a little dot point under there, or a little question mark around a new program, because that certainly had been announced through the Medicare Task Force review, that there's a thinking pathway towards more tiers in between just the 1 and 2, and also possibly higher payments. I have heard about double payments, but it hasn't been confirmed. So we really can't provide that information at this point in time, but we'd really encourage you to just go to the website, the Medicare website, have a look at the practice incentives program, look for the aged care access payments to just understand whatever the currency of that program is at any point in time. So that's what's available at this point in time. And we're now going to flip over into the new temporary item numbers. I guess before we sort of delve into the item numbers, we're calling them temporary item numbers, Kim, because we know that at this point in time, they're stretching through until the 30th of June 2022. So at this point in time, they're time limited and they may not extend beyond that. But as we've kind of figured from learning about all of these new services, that there is a high likelihood that they will have a life after that. What's your thoughts around that? Do you think it's going to happen?
Absolutely. And I think that my key takeaway here is that if we don't use them, we're going to lose them. So it's taken many, many years, hasn't it, to compile the Royal Commission. Big advocate for that piece of work to be done. I've had loved ones in residential aged care facilities, and I know how vital these new services are going to be in terms of making quality of life for residents, and also for that wraparound care as well for interdisciplinary team members. And there's new item numbers for new services that we haven't had before. So as I said, if you don't use them, we're going to lose them. So if you can think about ways that you can start to implement or optimize workforce to start to use them, we're thinking about that end game. Why are we doing this?
And look, you've elaborated on that so beautifully and sort of really getting to the heart of that. So what are these new items? Well, first of all, there are some new item numbers. So we're talking about a 934, 69 and 70, and the differentiation between those is for vocationally registered GPs versus non-vocationally registered GPs. So that's the sort of the slash item numbers. And it is to contribute to a care plan or a review. And these new item numbers certainly have similarity to the 731, which is the contribution to the RACF developed care plan that we just mentioned in the previous slide. But there are some differences, so we'll run through those in just a minute. There is now a brand new, in bold letters, an Aboriginal Torres Strait Islander health assessment. And this is just so curious, isn't it, Kim, that the equivalent of the item 715 just wasn't there for RACF residents. It's just extraordinary, isn't it? So that's a brand new one. Any comments?
Oh, it's mind-blowing too. I'm really quite happy to see it there. And as I said, if we don't use them, we're going to lose them. So can we access additional staff members or workforce to assist with those additional items, because they're just vital to the integrity.
Exactly. So again, this is a health assessment. You know, the remuneration on that is very similar, equivalent to the item 715. And of course, for our Aboriginal Torres Strait Islander community who are in residential aged care, of course, they need to have access to those deep dive health assessments in order to support them. So that's a brilliant new addition. And I really hope that we get really good traction on these item numbers. So let's go back to the comparison between the new multidisciplinary care plans and the existing ones. So the existing ones, the 731s, 232 for the OMPs, versus the new ones, the 93469 and 93470. Again, that second number for non-VR GPs. So you'll see there is a little bit of similarity there in that they can both be prepared three monthly, so not sooner than that. And certainly there is a recommendation to have that regularity around that. That's probably something that is still missing a little bit, or missed opportunity to actually really reflect on those care plans and regularly review them. In fact, in other conversations, the ideas are really around the fact that, you know, perhaps sometimes what's happening is that attendance items are taking the place of what really should be care plan reviews. So, you know, so there's some thinking points there as well. So the difference is then. I'm sorry.
No, we also know from the MBS task force review findings that regular reviews actually impact patient outcomes.
Of course it does. And look, I mean, you know, this really starts to flip back to that whole space of chronic disease management, doesn't it? That proactive planned care sees better health outcomes at the end of it. That's not a new conversation. That's been around for a long time. And of course, it's no different for residential aged care facilities there. Now, so it's just some of the subtle differences in terms of the MBS item number descriptors. So the 731 item numbers are in the attendance section of the Medicare benefits schedule. And for the new item numbers, there is a specification of a face-to-face service in that item descriptor. So this service can't be a telehealth service. So that's a little bit of a difference there. Now, one of the key differences, and one that I think ought to be one of the take-home messages from this session, is that for the current item 731, or the older existing one, there is a very explicit restriction of claiming this item number with an attendance item number. And when I plowed through the MBS looking at the new item number, that co-claiming restriction with an attendance item is simply not there for the new item numbers. So what that means is that there is now every opportunity to include an attendance item with a review or contribution to a care plan, as long as the item descriptors for both the attendance item and the care planning item are fully committed and fully documented. So please review the MBS on these items so that you're very clear on what your obligations are in terms of, co-claiming and making sure that you don't fall foul of the Medicare requirements there. Exactly. And of course, if there are any other services that are provided as part of the attendance that is provided, for example, the provision of medication or other medical services that are provided that are not directly related to that care planning contribution or review, then there is no reason why a practice wouldn't charge that together with an attendance item. So, that really does start to support the services a whole lot better too. And of course, these items all count towards the practice incentives count per year of reaching those goalposts. So that's important too. For the existing item 731, there are no explicit requirements or stipulations around documentation, although of course you would still want to be doing that. But in the new item numbers, there are very explicit instructions around that. So really do look at the documentation very closely. With the old item number, there are a raft of explanatory notes that are part of that item descriptor too, so it's definitely worthwhile reflecting on those, and they are not part of the new item descriptors. So let's have a look at what each item actually requires. So for the existing 731, it is all around the core plan prepared by the residential aged care facility. And it basically asks for a contribution to a new care plan or a review of that care plan, or a contribution before a patient is discharged from hospital to go back into the care of a residential aged care facility. The new item number has 4 different elements to it, and it is an either or situation. You certainly don't need to fulfill all of those. So this is what it states. You either prepare part of a care plan and document it. So this is where that documentation specificity comes in, or there is the preparation of an amendment and documentation of that amendment. Or it is about giving advice to a practitioner who prepares the care plan, and then that advice needs to be documented. And then the last one is giving advice to a practitioner who reviews the care plan and documenting that. So you can see it's a far sort of looser description of the kinds of activities that now constitute a provision of a service towards that multidisciplinary care plan. So there's vagueness, but there is also a broader sense of activity that now falls within the remit of these new item numbers. And, I would really encourage practices to think about what that means for the way that services are provided, and perhaps identifying new opportunities for charging this new item number 93469 or 70 rather than a 731. So it's about broader thinking about that whole care planning process. Any thoughts on that, Kim?
I do. We want to think about team-based care as much as we can. What can you optimize in terms of staff input and workforce to assist you with this? Is this something that you co-develop with your workforce rather than, so if we're thinking about traditional care planning in GP land, we often have a team base, don't we, that provides those services. So we'll utilise nursing services in addition to the chief executive of the care plan, the GP's input as well. So is that something that you want to develop as a model of care moving forward, that you actually have a team? If the residential aged care facility aren't providing that documentation and providing that care plan for you, are you having workforce yourself that's developing that, and then you're signing off on those when you're going off to provide other services, because you can co-claim, obviously.
Exactly. So that's a little bit about existing and new multidisciplinary care plans. So let's have a look now at what the existing mental health services look like in residential aged care facilities, because it will also help with the context of what the new services are looking like. So at the moment, prior to the new items, there were services that were covered by aged care funding, but they were not eligible for Medicare benefits schedule payments. And so these kinds of services really sort of bypass primary care to a large extent. But that has been lurking in the background. The degree to which those services have been successfully provided, I think that's been variable across regions, but that's certainly been in place. There are also state and territory older persons mental health services, which is for RACF residents with complex mental health needs. So again, this is kind of sat quite aside from the services that primary care provides. But previously, there were no provisions for providing mental health care services through the MBS at all in aged care facilities. And again, through the task force review, it was identified that that was a glaring omission and something that needed to be remediated.
And the Royal Commission as well, Riff, said that we've seen rates of depression and anxiety like never before as a consequence of COVID-19, that isolation piece, right? So it's
absolutely, and all of those all of those, I guess, different pockets have all come to the same conclusion that these services are desperately needed, and now they're on the table. So that's a great thing. So what do MBS mental health services look like in RACFs? Well, they're quite aligned with the better access services that are already available just through normal GP services. So the item numbers are split amongst practitioners who have taken up the skills training in mental health versus those who have not undertaken that skills training. And it's no different for this RACF service provision. So the applicable item numbers in that space is 93400 to 93411. So that is around the development of the mental health care plans. And these are time-based. So, whether it takes 20 minutes or, 40 minutes, whether you're a GP or whether, a vocationally registered GP or a non-vocationally registered GP, all of those things kind of play into that space. And it certainly covers off also the reviews of those mental health care plans. And there are also attendance items as part of this space as well. Now, interestingly too, it includes both face-to-face and telehealth service items as well. Now, we're really close, as we are recording now, to the end of June 2021, and we are still yet to hear whether telehealth items are going to progress beyond the 1st of July. Again, my gut probably tells me that that will happen because, COVID's not going anywhere, is it, Kim?
Greg Hunt has gone publicly and said that they're going to continue with what we've yet to be divulged. But I think what's important to highlight here, even though it is so close to the end date, hopefully they expand it out, is this will address some workforce issues as well, won't it, Riff? Like some mental health practitioners can't be accessed in some areas. So having that telehealth capacity really starts to allow people to leverage those services.
Yeah, absolutely. Absolutely. And so with these mental health services, where psychologists especially are getting involved and social workers and the like in the delivery of some of those support services that stem from the mental health care plan items, there certainly is a referral required from a GP or a psychiatrist. And of course, those referrals are linked to the mental health care plans. So again, that's not ostensibly different to the usual way of working with mental health care plan items. So in terms of the new MBS items as well, in terms of the focused psychological services, so this is kind of the next step aside from the mental health care plans, is actually providing that intensive support for the clients, for the residents. So out of the care planning, available is up to 20 individual focused psychological services. And that can either be done by a GP who has undertaken that additional skills training or by a psychologist. There is a flag fall that applies to these services as well, but that of course is only for face-to-face services, because if you're providing a telehealth service in this space, then you're not actually going to the RACF, and therefore that flag fall doesn't apply for that. So the way that the services are split, again, it's not a great deal different to what you may already be familiar with, is an initial 6 services followed by a review and an additional 4 services should that be required. But on top of that, there are an additional 10 focused psychological therapy services available, and the item numbers are listed there as well. Now, there is quite a degree of complexity as far as the item number structure is concerned. So I'd absolutely refer you to the mind map to really get a clear grasp of how those services run and which item numbers are appropriate for, for your circumstance, because, depending on where you are and whether you've got psychologists or whether your GPs are providing focused psychological strategy services, all of that will impact on how that service actually runs out. There are also, I just wanted to mention, the Better Access bushfire items, similar program, but it is a separate program with its own item numbers again. So, these are some of the bits that kind of make practices scratch their heads, don't they, Kim, to go, which one are we tapping into? Is this a bushfire related item? Is it, COVID-19, or is it, is it something else? So look at the mind map and see where it pitches there. So in terms of mental health, there are other services available as well beside the MBS services, and it's really important that practices know about those as well. So a number of PHNs do commission services directly, and these are around stepped care, early intervention types of programs. So there is quite specific eligibility for RACF residents in terms of whether these services are appropriate for them. And I guess it's around the sort of the lower acuity, service need, and there is a whole lot of that required as well. Now, the interesting thing with that is that it doesn't actually require a mental health care plan to be in place, and the referral can come from lots of different areas. It can come from the resident themselves, so it's important that residents know that they have that access through those, through those services as well. It can come through the RACF staff. So again, they need to know that they can tap their PHN on the shoulder if they are a commissioning PHN to actually deliver those services. It can also come through family or friends. So it's a really, it's quite a unique way of service referral, isn't it, Kim? And certainly one that I kind of went, oh, that's really neat. I wasn't aware that, that eligibility was, quite as broad as what it is. And so we'd be encouraging everybody to just tap in with your PHN to check what those commissioned mental health services look like and what are the mechanisms that are in place for actually obtaining those services. I would imagine that most PHNs are, spruiking those services to the right RACFs and to the practices as well. But it's kind of good to get that two-way conversation, I guess, going so that everybody is on board with exactly what's on the table there, and just to be aware that this service isn't offered through every PHN, so that's a limiting factor there. There's also Beyond Blue, so that's available to the general public, but don't forget that includes the RACFs as well. And there is also Head to Health, which is a more recent program available as well. You certainly should be able to tap into that through your PHNs as well, and it just provides another opportunity for referral for mental health support for RACF clients.
And I think one of the takeaways there as well, Riff, is go to your health pathway site. and
Oh,
check
absolutely.
what's available in your particular PHN. Just find out what mental health services, what commission services, what local services do you have access to, and national bodies, as Riff just highlighted.
Of course, health pathways. It's your local directory, isn't it? You know, that's and it's going to be region specific. So yeah, and it's kept all well up to date. It's a fabulous resource. So we've just spoken about some of those mental health services. There are also now new services available as far as allied health services, and there is overlap between mental health and allied health as well, but there is also new service streams there as well. So to get our heads around that, let's just backtrack a little bit more again and look at what's already available prior as far as existing allied health services to RACF. So in times gone past, the RACF allied health services have been restricted only to face-to-face items. You'll recognise these item numbers 10950 to 10970, depending on the allied health service that is being tapped into. And they stemmed from the contribution to the care plan. So from the 731 activity, those 5 allied health services stemmed very similar to the EPC process in general practice. So I've listed there the allied health specialities that are included, and you'll see, it's across the board, supporting diabetes and, audiology, dietetics, but you can also see mental health is in there. So, again, there is that overlap between what is a care plan item versus what is a mental health care plan item. What is the totality of the need of the resident, and how can we best support both their physical and mental health needs by perhaps splitting them out across a mental health care plan and the contribution to the RACF developed care plans as well. So that's there, not different.
If you're splitting 5 visits, why wouldn't you want to give them 20 visits if there's a need for them to have that?
That's exactly right.
Plan, and keep these 5 for so many other vast variety of services.
That is exactly what you'd be doing.
Yeah, yep. Sure.
That's exactly right. Now, I guess one of the limitations of the current or the older services too is that, there is just sort of a single item number, and the specification for that, it has to be at least a 20-minute service. So that's, kind of stock standard. It's pretty sort of, fixed in stone in terms of how that runs. In addition to those individual services, certainly group services have been available for RACF clients previously as well. So let's have a look at the new temporary, maybe not, health services. So now the services have been split into initial and subsequent item numbers. So that's quite a big shift from where it's been. So the initial services that residents are able to tap into, they are long service items. So it's recognising that as we kick off service provision, an initial service should be a deep dive into exploring exactly what this resident is going to require. And these new item numbers are cognizant of that and supporting that. So in order to tap into those services, residents must have a care plan in place. And per service type, only one initial service is available per calendar year. So that's kind of the parameters around that. I've listed the range of item numbers. And again, those item numbers depend on the speciality or the allied health speciality that's being tapped into. And these services must have a minimum duration of 30 minutes. So that's good. Must be a face-to-face service as well. The subsequent standard items, so these are the follow-up services to that initial long one, is included in the maximum 5 services per year. It still has to be a minimum of 20 minutes, but there are now options of doing them face-to-face or using telehealth video services, video conferencing services, or more likely telephone services. We've certainly heard that, and I guess it's the same for, normal primary care services, that video conferencing has been really quite tricky. It would need to be set up very well at the RACF site in order to function well. But telephone services tend to be the preferred methodology for elderly patients to interact, with their services. And obviously physical services that require, the hands-on approach are not going to be suitable for these hands-off types of services. So that's kind of... Sorry?
I think that allows for services to continue, doesn't it? Particularly if there is lockdown area. So
yeah, it is absolutely about service continuity and tapping in. So you can see that there would be lots of service options where that would be a really good thing in order to keep that continuity going, keep the relationship going, making sure that residents, especially if there is a lockdown situation or a breakout situation, come what may, that these services can still proceed after that. It's very important. So these are the new temporary allied health services. But wait, there's more. It's not state knives, but there are some new additional services available after those 5 initial services that I've just described have been provided. So the restriction here, and that's why there is a big exclamation mark in this slide, is that the additional 5 services are only available for physical services, physiotherapy, occupational therapy, exercise physiology. Now, those additional services need to be included in the original care plan. If they are not, you would absolutely need to do a review of that care plan to reiterate the need for these additional services. So the need for those services must be included in that care plan. Those additional services, of course, they are physical therapy, so face-to-face services only. And we need to have a talk about the service combination issue, Kim, because this is kind of the bit that throws a bit of a spanner in the works, doesn't it? So
when we were both going, hang on a second, that's going to make it quite a complex combination of services, isn't it? And how you delve into your allocation of services might be, or distribute your services might be a difference than what you normally would just randomly go and assign. For instance?
Yes, so specifically, the issue arises where, for example, you have service provision that really spans a year, and I guess podiatry services and even dietitian services kind of explains that, where you wouldn't want all of those services to be taken up within the first 6 months of a care plan cycle, because you want those services to be provided at timely intervals. However, the new services only kick in after the first 5 have been delivered. So, for example, if 5 podiatry services have been planned over a year, then it is very difficult to tap into these new additional physical therapy services, because you can't have come to the end of your first 5, before time is up. And before you can tap into the additional 5. So the way that we need to think about this is, how do we deliver those services over the longer period while still being able to tap into the new additional item numbers? Any thoughts around that? What would be an approach that you might be thinking of, Kim?
Oh, well, it's again coming down to the region that you live in, i.e. the socio-economic status of your community members, the financial viability of your residents. There may be a cost distribution off to podiatry services so that you're not waiting for podiatry to finish. Say, if we're mapping from January to December, if you use up your last one in November, and then the client's going to miss out on all these deconditioning allied health services. So, you might actually distribute some of these other services, other EPC allocations, to other interdisciplinary allied team members. and have maybe the resident pay for some podiatry, or there might be podiatry services offered by the residential aged care facility. So that's what I meant about delve and distribution, but it's going to be an individual basis. It's going to really have to be contextualized, isn't it, to the environment and financial.
Yeah, exactly. I think it's also probably a good idea at this point to just be really clear that where RACFs have commissioned services, so allied health service providers who work from the facility or with the facility through an arrangement outside of the MBS, that residents should tap into those, but there can't be any double dipping. So those services are not appropriate for MBS claiming as well. And so, where it's provided by an RACF and that's working well, that's great, because it means that you can segregate these care planning services to the modalities that are most needed. And just, to be really aware that there are different funding buckets that kind of support the same kinds of activities. But what we know also is that those services that are directly engaged by RACFs, they can be more fragmented in terms of, more than one service provider doing podiatry, or more than one service provider doing, dietetics and the like. And so that service fragmentation can be poorly received by the residents, or it just might not be the preference, or the best health outcomes for the resident. So that's kind of where some of that complexity sits in with these new item numbers. And I guess we would really encourage RACFs and GP practices to have conversations around this and kind of map out what does it look like and how can we best work together to make this work.
And Riff, I'm thinking case conference, right? Case conference to work it out and find out from each individual perspective what's going to work best. But not only that, how can we record what the patient's had, or the resident in this instance has had in terms of allied services, so we know when those next 5 will be activated, so that we're always having front in mind of that why, better health outcomes, deconditioning, making sure they're getting that mental stimulation, etc., that we are using these item numbers.
Yep, exactly. And well, of course, we know too that there are constraints too around resourcing, and you got to make sure that you've got these allied health professionals available to tap into, and that's another story altogether. It's easier in some locations and very, very challenging in others. So you just got to see what's available, and using health pathways and tap your PHN on the shoulder and shake that tree and see who falls out as far as allied health professionals is concerned. So let's have a look too at the new group therapy services that are available as well. So these are in addition to services that must be provided by RACFs at no cost. So again, just be aware that that is mandated to the RACFs. They must be provided. So additional group services are now available through MBS as well. And that's up to a maximum of 10 per calendar year. So that's really a good spread of service opportunity. Flag 4 applies for, again, face-to-face services. And the modalities that are included for the group therapy services are diabetes education, exercise physiology, and dietetics. And underneath the exercise physiology services, there are an extra 2 available because of the recognition that it's that exercise physiology support that is just so important in achieving some of those health outcomes and mobility that that Kim has already spoken about. And in addition to that, there are also PHNs that commission group therapy services and it would be in addition to that again. So again, depending on what's available in your region, those group services could be fantastic opportunities for residents to actually come together. That's meeting a great social need as well, learning about mobility and, really keeping those residents going as well. So those are the new group therapy sessions available for allied health as well. So let's delve into this a little bit more. For each of the allied health specialty, this is the way that these group services actually run out. So there must be a first initial meeting with the RACF to discuss the program that's going to be rolled out. Now, for the different modalities, the prescriptiveness of those programs is actually quite strict. So there's like a whole curriculum that is expected to be rolled out through these group services. So it's not just get together and we're just going to have a little bit of a chit chat. They are very determined programs in the way that sort of any sort of structured curriculum would roll out. So that's really good. There is then also a face-to-face initial or individual service per participant as well. So they must have that service to get that initial assessment happening as well. Then there is 2 hours of face-to-face per week per participant. And then there is up to 26 weeks of therapy. Now, the 2 hours face-to-face per week is the totality of the service. So it's not per group service, so it doesn't sort of keep multiplying out. So again, service split across different modalities and different groups is going to be really important to work that out well. And of course, this is not so much where primary care is concerned. This is more between the RACF and the allied health providers to work out the dynamics and the workflows of those group services as well. And like I said, there are very prescriptive underpinnings to those group services. Just want to also point you to a brand new COVID flag fall that is now also appropriate for residential aged care facilities. This is an item number 90005, which has been in existence for a while, which is around the flag fall for COVID vaccination readiness, suitability. So the COVID items haven't been available for RACFs through primary care before about a week ago. So again, this is kind of brand new. Thank God that, COVID vaccination eligibility services are now coming through primary care as well, because that's just been the missing piece too when we sort of reflect back on COVID vaccination rollouts. And just to be aware that the flag fall applies to this item as well. So that's probably the last of the newness there. The newness there, not strictly related to mental health and allied health, but we certainly felt it would be remiss if we don't sort of, bring to you all the bits that have just come to our attention as far as RACFs are concerned. So that kind of wraps up the services, the new MBS services for RACFs.
So thanks, Riff. That was a really comprehensive overview and walkthrough of the what, the why, the how, what was in existence, and now what's new. So hopefully you really enjoyed that and found some great insights. Again, go back to the mind map for more comprehensive thought, thinking, strategizing, and we look forward to seeing you in the next recording. And of course, third recording, we have some special guests who talk about the real life scenarios and contextualization of these new item numbers.
Thanks, Kim.